The next effect is a truncus arteriosus. Truncus arteriosus represent less than 1% of congenital heart diseases. In this disease, there is a single arterial trunk coming out from the heart with a truncal valve, giving rise to both the pulmonary and the aorta. There is a large perimembranous VSD direct below the trunk, and the truncal valve may be bicuspid, tricuspid, or quadricuspid, and is often regurgitated. This anomaly is divided into 4 types by how the pulmonary arteries arise from the truncus arteriosus. Type 1 and 2 constitutes 85% of cases, where in type 1, the main pulmonary arises from the trunk and giving rise to both branches, right and left pulmonary arteries. Type 2, both right and left pulmonary arteries arises from the back of the trunk. And type 3, they are arising from the sides of the trunk. Type 4 is not actual a truncus, it's some variant with severe form of fallow and pulmonary atresia, what we sometimes call as pseudotruncus arteriosus. The pulmonary blood flow is usually increased in type 1, nearly normal in types 2 and 3, and decreased in type 4. There may be a right-sided aortic arch in 30% of these cases. Clinically, these patients present with mild cyanosis immediately after birth. Usually, there are signs of congestive heart failure within several days to weeks after birth. Usually, there is dyspnea with feeding, failure to thrive, frequent respiratory infections. By physical examination, there is varying degrees of cyanosis, signs of congestive heart failure, tachypnea, dyspnea. The peripheral pulses are bounding with wide pulse pressure, hyperactive pericardium. The apical pulse is displaced laterally. There is single second sound, systolic murmur or VSD, early diastolic murmur of the truncal valve regurgitation may be audible. ECG shows a normal QRS axis biventricular hypertrophy in most cases. Chest X-ray reveals cardiomegaly with increased pulmonary vascular markings. Right-sided arch may be seen in 30% of cases. Echocardiography is diagnostic by a large VSD seen under the truncal valve, large single arterial trunk with the characteristic pulmonary artery branching pattern according to the different types. It also shows the type of truncal valve pathology, the number of sinuses, whether it's bicuspid, tricuspid, quadricuspid, shows the absence or presence of stenosis or regurgitation in this truncal valve. Right aortic arch can be also present. Other studies, cardiac catheterization may be indicated if the patient is presenting late to study the pulmonary artery pressure and the pulmonary vascular resistance. So what happens for these patients if left untreated? Mostly they are presenting with congestive heart failure within 2 weeks of life. 85% of cases, if left untreated, die by the age of 1 year. Clinical improvements will develop if the patient starts to develop pulmonary vascular disease by the age of 3 to 4 months of age, and then death will occur by the 3rd decade of life from Eisenmenger syndrome. Truncal valve insufficiency will worsen by time. Medical management of these patients include vigorous treatment with anticongestive measures like diuretics and ACE inhibitors. The condition is associated with DiGeorge syndrome in some cases, so we need to assess serum calcium, magnesium, In case of blood transfusion will be needed, or irradiated blood product should be given. And because these patients are usually thymus-based immune deficient, treatment prophylaxis of pneumococcal and streptococcal infections are important. Prophylaxis against infective endocarditis also should be indicated. Surgery should be done within the first weeks of life before the patient developed pulmonary vascular resistance and after medical stabilization of the general condition. For all cases, the VSD should be tunneled towards the should be closed so that the left ventricle ejects the blood into the main arterial trunk. For type 1, where there is a main pulmonary artery arising from the trunk, it should be disconnected from the trunk and connected to the right ventricle by a homograft, like a duct. Type 2 and 3, the area of the trunk with the pulmonary artery branches, either from the back or from the sides, will be removed, mobilized, and connected to the RV with a valved conduit. And the aortic continuity should be restored by a tubular graft. The truncal valve should also be repaired, and if repair is not suitable, is not successful, the condition may end up with tubular truncal valve replacement, which carries the risk of mortality up to 50%.